That lifelong learning, I mean, it's thrown around all the time, but, frankly, I do it for pure selfish reasons. I mean, from a neurocognitive perspective, I want to be as bright and keep my brain as healthy as I can, right? And we know that that's do novel things, learn new things. I mean, and why not learn things that, you're passionate about and can actually make a difference? That natural curiosity you have to have in that post-professional area.
Well, Tim, welcome to the show. I'm super excited to talk to you. I'm over here in North Carolina. Tim's in Colorado. Tim is somebody that I've had an opportunity to get to know a long time now ago. It feels like it shouldn't be that long ago now, but it's exciting to have him on the show today and really get to talk, about some things I think that are really important, especially with regards to manual therapy and education and sort of what manual therapy education looks across the educational lifespan. And I can't imagine anybody being able to really have this conversation better than, Tim, because he really has been on all sides of the education adventure, being both consumer and as well as a deliverer of education in various pathways and journeys in people's lives. And so, Tim, welcome to the show.
Well, thanks for having me. I'm really looking forward to the conversation today, Derek. And yes, we go back, I guess, a long ways now, which is kind of wild for sure. So,
Yeah, I still remember that it was 2008 when Evidence in Motion was, kind of getting off the ground, and you trusted a few of us lowly schleps to be a part of the organization in regards to fellowship training and such. And I'll always, value that time very well.
well, I think that since we are talking about education, I mean, I look at, I, like you, have been super fortunate that I was put into positions to teach way before I thought I was capable of doing it by people that I were very well respected, Phil Greenman, John Badillan, John Manel. It was, I'm around these people and I'm way too young. And, I guess they call it imposter syndrome now, but, you're just saying, wow. Having said that, that's really what our role has always been, I think, is to empower, those around us to just do better and to be better than we are in terms of both the practice of what we do, but also, teaching others going forward.
Yeah, I'm glad you brought all that up, and I think one of the things that I've always respected about your position is that you've always maintained sort of the foot in the door of clinical relevance as well too. So I think that that's always meaningful. I think we all start in some way or form with educating PTs, in that clinical setting. I remember when I first got my first student, I think I was only out 6 months of PT school. So talk about imposter syndrome. I was teaching a student as a CI, from somebody who, was only going to graduate 6 months before me. And somebody asked me how that went. I was like, well, I don't think I could really teach them much, but I could kind of help guide them a little bit. But I felt like there's always been that imposter syndrome, even for everyone. I think is kind of refreshing to hear. Um,
Indeed.
so I have the topic of our conversation today is, and it's about physical therapy, and probably more importantly, I think, especially for our listeners here, orthopedic manual physical therapy, future in education, and how it starts with the education setting and environments. And I think we wanted to talk about it from the um, professional side of education, so entry level education going through post professional education, and I might even add a little bit in there. This wasn't part of our initial discussion, but post professional educational journey, because I think a lot of us are now starting to face that part of our career paths. And so, uh, I guess before we even get into that, let our listeners know how you really kind of became interested in manual therapy specifically. I think we all are familiar with the work that you've done and the research that you've contributed to the field, but like, where did it all start? How did you get interested in this? How did you get the bug?
Well, it's funny because I often joke my manual therapy training. I went to Marquette, graduated in 1983, and we had a 4-hour block on manual therapy. That was the extent. And not only was that the extent of the block, it was on a Friday morning. And the Thursday night before, my wife and I had gotten engaged. She was in PT school. And of course, we were provided with way too many cheap shots. So I just remember that next morning being super hungover, and that was our only manual therapy block we got. I mean, I was super excited given my state. And so that was really my initial entry into manual therapy, but it was just a sliver.
How that won you over, I don't know.
So, but actually, I was in ROTC, so I went into the Army right out of PT school and was stationed down in San Antonio at Brooke Army Medical Center. And I was, life is a lot. People say it's hard work, but it's luck as well. I mean, I could have gotten sent somewhere differently, but at the time, it was just kind of a bevy of super outstanding physical therapists, musculoskeletal imaging, but manual therapy as well. There's a couple. Steve Stratton was one, and that just was, going to Michigan State osteopathic program at the time, their continuing education program, and just saying, hey, this is where you need to be at, this is where you got to go, etc. But I was just immersed in this musculoskeletal world, and you just were expected, to know this material and to be good with your hands. And so I think I was lucky in that regard. But my first exposures were, teaching, just extremity manipulation and spinal manipulation, people with acute pain syndromes coming in. And then very quickly, I think it was a year or two in, I went to Michigan State for a 5-day principles of manual medicine course. And that was a game changer because it really, first, it was a small group of primarily DOs, couple MDs, and a handful of physical therapists. But again, the faculty was, it was Phil Greenman, John Minnell, John Bordillon, I think Carl Steele, who was a PT, but then went on to become a DO. And, it was like a student faculty ratio about 1 to 6, or 6 to 1. And it was just an immersion. And I realized how little I knew, but how powerful it was. And that these folks, two had which been orthopedic surgeons and had given up essentially surgery because they just believed in manual medicine, non-operative care, back in the, this is now the mid 80s. So it was very powerful, both from the technical aspect, but also from the professionalization of what manual medicine really was. So that really launched my career. And, when I ended up going back for my master's, I guess it was in 88 to 90, I went to Michigan State in the osteopathic school. They had a biomechanics department, which was somewhat traditional biomechanics in the fact that we're doing a lot of tissue mechanics and stress strain curves and the like. But Phil Greenman, Dr. Greenman, was a member of that faculty, and I knew if I went there, I could take more of these courses while I was there. And just kept pestering him until he said, well, Tim, why don't you just come to clinic with me a couple of days a week? I'm like, yeah. And so that was like, the beginning of the quote classic kind of mentorship of, one-on-one in the clinic, 12, 16 hours a week, just watching a truly master clinician. And that's when you realize manual medicine is described there, and manual therapy or manual physical therapy as we now know it, it's holistic. And technically, yeah, he was a skilled manipulator, but it was all the other stuff, his patient interaction that we now call therapeutic alliance was off the charts. You just wanted this guy to be your doc. I mean, it was just connectivity with people, and could be very firm on, hey, you got to do your homework. Um, but came from a place that you just trusted. And so, yeah, you look back, and those elements just launched my passion and career, and which goes to say how important it is, I think, that early career therapists, you know even if it's harder yards, and not getting paid as much, it does shift your entire trajectory if you can have those first couple of years around people that actually are doing it the right way, and are really patient focused, and understand, despite the system that's really broken, that we can still make a difference, and that will truly launch your trajectory, I believe.
It's interesting that one of the things I picked up on when you said there, and I've heard this from a lot of people who have gone on to be successful in their careers, is they pester, they beg, they yearn for the mentorship. They take charge in their own education. And I've had a lot of conversations around that with DPT students, and I'm sure we'll get into some of that conversation later about some of the generational changes and differences and things like that. But I still think that there's value in taking charge of that. And everybody that I've met that's done something very well is they're basically like, just they don't stop knocking on the door, and eventually somebody's going to open that door and say, okay, fine, I'll let you in. But if you look across the board, that seems to be one of those character traits of a somebody that has gone on to become a great clinician, and then have some level of impact, whatever that impact might be defined as. So nice and refreshing to hear you say that.
And it just occurred to me as we're talking that part of, I think, that trait is you are um, vulnerable. You're going to get told no. You're going to be putting yourself out there. And I think there's an openness in that. I think maybe it displays a bit of openness in how you then view science, how you view learning, how you view growth. And so maybe part of that is just a trait that you kind of that needs to be there in order to grow, I think.
Yeah, it's one of the things that I actually tell even our students, and when they're learning things, either if it's either an entry level PT student or if I'm teaching fellows or whatever it might be, I always say, here's two things you have to do. You have to give feedback, and then you have to crave feedback, even if it's feedback that you don't necessarily want to receive, but you have to beg for that level of feedback, because ultimately that's going to help you grow as well too. So, I think that that's a big part of that educational adventure.
Mhm.
So, I know your career track and your trajectory a fair amount, and so coming out of the military, obviously you were a consumer of education, you were taught, and then at some point, and you're always a learner. So I'm not going to say that you're not still learning, but at some level you then changed, and I know that you went into sort of almost a post-professional focus of education, and then kind of shifted into some entry level back again. But uh, talk to us a little bit about what I guess was the next catalyst, if I'm going to think about phases in educational journey, where you started to say, hey, you know what, we need to do something bigger. Maybe we need to educate at a larger scale, or a larger shift, or something like that. And that was probably the early 2000s. I'm sure that happened, but talk to us a little bit about what kind of went into your mindset around all of that.
Um, well, I mean, there's a few things there wrapped in there. I think it has, I think as it relates to AMPT, I think there is a story there that we'll get to that, because I really think my passion for manual therapy, I mean, my PhD was not that. I learned a lot about a little, which PhDs are. You learn a method, you learn a lot, and it was really in bone stress injuries and things that were away from manual therapy. And this is in the 90s. So I come out in 97. The ACPAR guidelines are saying, PTs don't do anything for back pain, except, this manipulation thing seems to have a little bit of benefit. And our own professional association didn't jump on that and say, well, hell yeah, that's what we do. So we kind of fought those guidelines as well as everybody else that didn't like what the answer was. And so I came out during that time a little like, whoa, I'm a manual therapist, even though I've kind of done this PhD, and I was back into entry level teaching. And I felt strongly that, these skills are basic skill sets of entry level professionals, that you need to know how to manipulate the spine. You need to know how to manipulate the extremities. And that's just a basic skill set to manage. One of the largest conditions we see is that of spinal disorders. So that to me was obvious as I entered, I was now at Army Baylor, and so I was teaching there. But I also became a member of the academy. And at that time, I just assumed, we were pushing, manipulation and entry level practice, that was just a basic skill set. And I wasn't, met with quite the excitement that across the academy. And again, it was well intended, but a lot of folks felt that this was a higher level post-professional skill. And clearly you get better and better post-professionally, but there are a skill set that are really all of us need to have in entry level. And we now do that, but that wasn't at the time, the prevailing wisdom. And why I was passionate about it was because the need was there. And I look back to my education where my mentors, osteopathic physicians, one in particular, Phil Greenman, caught hell for teaching PT spinal manipulation because they felt that a lot of the osteopaths felt that, no, that's within their realm, and that shouldn't be done. And he was like, well, hey, who's going to be doing it? Because he was seeing way back in the 80s that physician graduates of DO schools were migrating into traditional residencies and really becoming more traditional silo-based specializations and losing their manual medicine skills. And it was very intentional that says, if we don't continue to teach these skills, they will be lost, and we will not have this skill set in U.S. healthcare. And so that's why I, in the back was very passionate about having that be a skill set of PTs and entry level. But to your question now, then, scaling up post professionally, I was just fortunate, again, somebody picks up the phone and wants to be part of your wants them on your committee, and the person on the other end of the line was a guy named John Childs, and he wanted to do this RCT, and I'm like, well, yeah, I'd be happy to be on your committee and whatnot. And he describes it as being a very nervous call to someone, like this expert. And I was looking like, oh, this young eager person wants to collaborate. That's awesome, and so, but from that, we did research together, and clearly evidence in motion begins to formulate. I was already doing some CD production back in the day, doing little digital Mavica Sony 15-second video clips and smashing them on a CD. I don't know if they have those little discs. They're called CDs. They have those things anymore. But yeah, so we were, my
Lisa
wife
wasn't
and I.
VHS.
Oh, okay. Indeed. So, but yeah, so that quickly we realized the demand for, continuing medical education was continuing to be there, but ultimately the data also was showing that wasn't changing behaviors, right? You just didn't change behaviors with just one-off CEs. You needed more ongoing connectivity with people. And that really, from that stemmed, really residency and fellowship training and certifications and post-professional training that was more skin in the game, if you will. It was longer, so that you kind of had to commit a bit to doing that. And I look back in my career and even though I wasn't in the formalized system, I was going through a series of courses that would be certificate-like, but the people around you were equally hungry, and you'd go to class all day learning these techniques, and then you'd eat, and then you'd grab a table, and then you spend the next 3 hours practicing, with 3 or 4 of you, like making sure you really had it, before the next day. And that passion, you know, I think really makes the expert, where you gotta get reps, I mean, you do it one or two times. It's now I'm learning to play golf. And, man, I can tell you that the amount of reps to just get minimally competent is a ton. I mean, that's just to get minimally competent. And I think it's like any motor skill, you gotta be passionate about it. You gotta do the reps. And so that really led to more of the certification, residency, fellowship kind of training that we got involved with.
It's so this is a little sidebar because you mentioned your PhD, and so for our listeners out there, I actually unearthed some of your original PhD work because I personally had a bone stress injury, and I was like, that can't be that Tim Flynn on those studies, right? And it ultimately was, and I was like, wow, that's pretty cool. I didn't know that you had that sort of background. Then it obviously now I know how it really just morphed really quickly back to manual therapy, but there was a brief flirtation apparently with bone stress injuries.
And I'm still quite interested in them. And had I gone a different route, I probably would have continued on. But I was, in the era of PhD where you have to do something novel, and so I was trying to figure out if this vibrational characteristics of tibias would be related prognostically to bone stress injuries, which were very common in the military, the tibia. So, and I got the instrument to be reliable, and then once I got back into the Army, we did some studies at Army Baylor, and it didn't pan out. That, I mean, there's so many factors involved that, but I was always big and still am that bone quality is a very different measure than bone density. Density is a contributor to quality, but that is just one marker, of health and of
Yeah.
quality. And so, yeah, still interested. And I read stuff here and there on it.
No, it was just funny to see out there. Bone stress injury might have been a little bit easier to handle than something ubiquitous like low back pain. A little bit easier to diagnose
Yeah.
and have an actual real pathoanatomical medical explanation, really, in some regards. But so you chose something a little more difficult and challenging, which is good. We're all happy you did. Uh, so, yeah, I think there's been a lot to sort of unpack here already a little bit. I want to take you now to where you are at currently, providing entry level education to manual therapists. And as you said, when you went through PT school, and even when I went through PT school, even though it was, some years later, um, it wasn't much different. Like we didn't learn, we certainly didn't learn manipulation. We did not learn, and then the manual therapy that we learned was, obviously based on a lot of theoretical models that would just typically confuse the heck out of somebody not smart enough like me to understand those things. And so, here we are now in a whole different era, and you're in a different era of your educational and teaching sort of career with that. What do you love, I guess, about teaching in entry level? I mean, I think that's where you're having a lot of impact. And I think, I love the topic of this because I do think that it's really important for our next generation of manual therapists to gain some sort of footing in entry level education. And we can do that now, whereas we couldn't do it before, yet we still were successful. I guess, yeah. What's your passion, and what do you see as sort of the future of education in manual therapy and entry level?
Well, I mean, I'm extremely passionate about it, and it is what our health system is so bad, and it's just crying for people that can think, that can have therapeutic hands, and that can, connect with human beings, because that's just, to me, part of the skill set allows us to actually move people to optimal health. And but you have to me, it's a window in to that, despite just the basics of treating, say, neuromuscular conditions with hands-on care. Um, I think the biases, what I like about entry level, we can, we're all biased, but we can at least not bias them according to even, I mean, within the century, people, are saying, the dangers of manual therapy and programs not teaching it because it's dangerous, and I'm like, it's just a wild thing that when you look back the history, we were doing manipulation at the beginning of, you know, in the 1920s at the beginning of our profession. I mean, that was the basics of our profession, was hands-on manual manipulative type care. So it's weird how things got distorted. But I really don't want to leave this talk with or discussion without saying that as the academy and the manual therapy group, our role is that of teachers. And I'm so excited. There's so many fellows that are on faculty throughout the country. And you look and talk to programs, and everybody, you know, says, they're excited about your orthopedic or musculoskeletal faculty. Well, there's a couple reasons. Almost all these are still clinicians. They're actually still seeing patients in some capacity, limited often just due to the other responsibilities, but are clinicians. They have stories about real patients right now, currently. Their passion for what they do exudes through. They're not telling stories of 20 years ago when I saw this patient, and students react to that. And I think that's where I'm curious, the number of fellows that are on faculty, it has to be quite high. And what's even more exciting to me is so many programs now are finally shifting, whether they're residency or blended models that, say, you know, those that should be teaching clinical skills should be clinicians. They should be expert clinicians. I don't want my surgeon taught by someone that doesn't do surgery. I just don't feel that's a good way to do business. It shouldn't be, the anatomy professor that's teaching it. It should actually be the surgeon that's teaching how to do surgery. And I think it's crazy how distorted our profession got away from the expertise of the clinician really driving the educational system. And so that's kind of what I'm most passionate about. And I think that manual therapy is really leading that charge in that through the fellowship programs, and that many of those graduates go on to be either full-time faculty or adjunct faculty leading, various components of the curriculum.
Yeah, it's fascinating. Like you said, manual therapy has been a part of what we do, and it's certainly a part of orthopedic management. You're not, by putting your hands on somebody and you establish that relationship as well, and you learn how to communicate and have empathy and all the other components that are around it. But it's not even just orthopedic care. I've actually talked to a lot of the faculty within our program who employ manual interventions across other types of settings. And I think and one of the things that for me, when it was time when I moved from primarily teaching post-professional education to moving into entry level education, I think I can't remember who it was that gave me this advice. They're like, but you got to be careful because you're going to have neurogeriatric pediatric interest from students in these programs. But I have found that, so I teach an advanced manual therapy class, and about 90% of the students in our program take that advanced manual therapy class, even if they're going into pediatrics or neuro or some other realm, because I think even they're starting to recognize the importance of hands-on care across all different kinds of specializations and areas.
I'm so hopeful that is the case. It's not a musculoskeletal skill. Yeah, we use it a lot in musculoskeletal care, but you know, I love when I see the predominant neurological diagnosis patient. I mean, again, most of these disorders end up affecting the movement system. When the movement system doesn't get to go through its range, it has impairments that need some hands-on care to get them through and to ease movement. And it makes it's so much sense. I mean, our pediatric team, at Colorado Motion, they very hands-on focused. I mean, they are manual therapy oriented. They don't think in anything of it, right? That's, so much have restricted movement systems. If you're not doing some type of manual intervention, you really are not offering them top of the line skill set, and again, you can move on into Parkinson's, another, example where, again, loss of full movements begin to create impairments at the joint soft tissue levels that make it even further difficult to move, right? And it, yeah, I just wish we'd get out of our silos. I mean, people are, and I just hope this new generation just sees it as, this is just, it's not a silo. We treat human bodies, and these skill sets cross all of our quote unquote, specialties of care.
Yeah, I think that's something that we're kind of seeing there. All right, so we're moving along in the journey, and talking about the importance of uh, manual therapy education in as a professional student level. Post professional education is something that you're still involved in. Certainly when we think about that, we think about orthopedic residency, I should say, and fellowship training. And what are your thoughts on that, and how important that is for our profession?
You know, Here I'll go up a level here in big picture. I think, you know, post professional training, ongoing learning is just, it's the nature of being a professional, So whether or not you go to residency or fellowship, hopefully at a minimum some type of certification pathway where you go deeper into an area of practice. I mean, yeah, a superficial knowledge of certain things, like, a patient comes in, they have a diagnosis I've never heard of, I can look up to get a basic understanding of what this diagnosis is, but, and I don't necessarily go deep down into that, specialization. But some specializations that I need, that are core to who I am as a professional, I need to. And you pick whatever that is, but I just feel that depth uh, versus breadth coming out of a professional program is necessary, because you got to go in deep. And sometimes, you go down a rabbit hole and you find, you're frustrated that you didn't get as much out of it as you wanted, but actually you did, because it's the discipline of driving deeper into an area of practice that allows you then to come back out and be, frankly, more efficient when you go down others as well. So I'm a big believer in whatever your passion is, to go down a pathway. And I think programs have gotten better at of putting into modules ways to do that. Again, where you could maybe do such a certification, and maybe that can build on into a residency model, can build on into a fellowship type model. So I think, various post professional training programs, whether they be at the university level or private level, are getting better at doing that. And I think as a consumer or student, can has more opportunities, at that graduate has more opportunities to find those. So that's my main, I guess, takeaway of that.
Yeah, no, and that's so good and so great. I know that every student is going to be a little bit different. I always talk to them about you have to self reflect, but at some level, if you find yourself not passionate or interested in seeking more, then it's probably a reflection of other things going on as well too, that you have to kind of think about. But there is, I think you even said earlier, sometimes you have to make those investments a little bit different in a way that maybe isn't what they're quite ready and comfortable for, but then the payout, whether it's financial payout or maybe it's just professional satisfaction, certainly comes into play as you go through those paths. I don't speak to too many people who have gone through, who have gone into the depths, like you've said, who have gone deep into the caves of things, come back out. Maybe they come away with some new letters, some certifications, some fellowship training, and things like that. They tend to be the ones that I find to be the happiest, the healthiest, in a sense, even though it seems like they wouldn't be because of the amount of like effort that it took to get there.
And it relates to, I mean, we won't go deep into, the problems of higher education, the costs, et cetera, but it's well known, right? And so part of it is, well, financially, it just doesn't make sense to continue to pour more in. And I clearly see the argument. And yet sometimes we don't talk about the fact that if you leave the profession, you burn out, and you leave due to dissatisfaction, which is often because you feel like you're not successful with clients. You burn out because you don't get the hit that you get when people are successful, right? When you have success around you and your patients and clients are have gratitude and showed gratitude towards you, you feed off of that. And it now does not become work, it becomes passion, it becomes truly your professional journey. And I do think that there's a cost if you don't have that, because you probably will leave the profession early, which is a financial hit, whether you have to retrain your skill set, which you will, into something else, or some other type of thing. And so I think it is that long game where you know you have to kind of play, and there's no right answer for an individual, these big broad statements, but I do think it's worth looking at it that way. The people that go in deep, they generally come out passionate, understanding, and have this longer longevity in the profession, because they results improve, and because of that, feedback from patients improves.
So I want to take us on a little bit of a different adventure before we conclude this show, because I think there was an article that just came out in JOSPT. It was a really good one. It was advice to the new grad, right? It was I think Jeremy Lewis, Chad Cook, and a few others were on that paper. Really nice paper. But here's what I want to ask you, because I think a lot of our listeners, especially Academy listeners, potentially are, a lot of our membership is fellows. A lot of our membership are people who may be thinking about fellows. Of course, not everybody. There's also non-fellow members, but they also have potentially have gone down a lot of depths and holes in their lives as well. So I want to go into the post professional educational journeys and get some of your thoughts on that. So what do you, you're the seasoned person, you have had some successes, you do feel like you are effective in a sense, but you're no longer in that sort of game of trying to build sort of this repertoire, resume of certain types of things. What does that post professional education look like in your mind, I guess? Curious.
Yeah, I mean, I think that's when you enter the phase that you truly are a self-directed learner, that you can really continue to grow by you seek out new knowledge, and you get more efficient at seeking out new knowledge. But I think that person, it I don't look at it as an obligation to teach, whether it be being a clinical instructor for an entry level, whether it be a mentor for a resident or fellow. um, I think it's very selfish that you should do it for selfish reasons, because that to me is that next phase of, and you may have been doing it all along, but you're doing it with a really different intent of, I want that new learner to challenge me on what is my belief structure and what's going on, and this back and forth nature, which then keeps me learning, if you will, going on. So I mean, I think that's just continuing to be engaged with, from a teaching perspective in whatever form, whether it be at the university or in the clinical environment. The second thing I would say is going in different directions, and that I think is key. Like I really have broadened. I mean, I've been, I think, holistic and open to a lot of new ideas, as we learn more about the neuroscience of pain mechanisms and things in the last 2 decades, and learning that. But then that exposes you to the fact that, oh my gosh, look at the gut and the gut microbiome, and how, wow, how this is affecting, you know, all these systems that I've been, teasing and using my hands with, and I haven't really been addressing that. You know, the same with breath work and breathing. I haven't been as detailed and had a deep understanding of that, how that interplays in what I'm doing with my manual interventions. And so taking those elements that complement my core, you know, clinical acumen, and making sure I'm bringing those into my skill set, and again, the same way, you got to go deep sometimes to kind of end up only pulling one or two things that, oh yeah, I always kind of do this now with patients. And I think our role obviously is distiller, right? We start with a wide range of information which is out there, but how do we make it really actionable to my patients in front of me? So I think that's the next phase of the post professional phase, is really taking newer ideas and being integrating those into practice, and then challenging the folks you're working with and teaching, what do you think about this? And this is my mindset, is that out there, this is why, watch me do this with a patient, is, what do you think of that? Is that, good, bad, indifferent? Again, asking for feedback, and hopefully feedback that is not just, as they say, good job, something that's actionable and actually critical, that allows you to improve.
No, I'm glad you did that. It was actually I kind of you took the bait because I wanted you to go down that path. I mean, the only reason why I wanted you to go down that path is it's something I've actually seen, not just from you, but from other folks who I have respected, where it's not just rinse and repeat after you've had your post professional education, where you just, okay, I've made it to the mountain, and now I'm just going to kind of do what I'm going to do. And I think that becomes sort of frustrating for the post professional phase of somebody's career. That's something that I've always seen, that I think very healthy people start to look at things very differently. And you can be sort of focused and myopic in some sense and still go into a lot of depths, or you can now start to expand your breadth like you have done, and certainly, look at things a bit differently. But I think that that's part of that excitement for a lot of folks, is that now you can go and see how everything functions and integrates a little bit differently there as well. But that's something I wanted you to actually say that, because that's something that I've seen you do. I'm like, oh, what is Tim doing now? Like, this was not Tim from 2002. This is Tim from 2024, and it's got some Tim still, but then it's got a lot of other integrated things as a component to what you do.
And I think that is that lifelong learning. I mean, it's thrown around all the time, but frankly, I do it for pure selfish reasons. I mean, from a neurocognitive perspective, I want to be, as bright and keep my brain as healthy as I can, right? And we know that that's do novel things, learn new things. I mean, and why not learn things that you're passionate about and can actually make a difference? And I do a lot of these things just and chat with people at the cocktail party or dinner party about, hey, I read about this is pretty cool, or I listen to this podcast, what do you think? And do you integrate this into your life, and how does that play? And I think that's just that natural curiosity you have to have in that post-professional area. And I'll say this, it's interesting. When I went to Fort Collins in 2003, there's Colorado has some excellent clinicians. I'll say that straight up. Just really, it was a very open state for private practice for, from the 60s and 70s, so it's a very open state in that regard. Lots of people, hanging shingles and doing things. And there was a good practice in town and that was doing, was really into this certain technique set, and that started in the mid 90s. And now it's already, now let's say about 2005, starting to see patients coming from that area, and excellent clinician, but a couple patients would say, well, yeah, I was going to him, but he's still doing the same things he was doing back then. And it stuck with me. And it, doing it well. And again, because I don't believe whatever you do it well, you're going to get good results, And I do think there's some agnostic nature to the quote technique, if you will. But it stuck in my mind, like, well, I don't want to be that. I don't want to just be doing, the same thing, 10 years from now that I'm doing now, even 5 years from now, that I need to continue to grow because, man, the explosion of knowledge, if I'm doing the same thing, I'm all this stuff I've read about you know, that I don't want to be, So I do think there's a lot to be said for that. And we have to challenge our colleagues and friends more, our friendly colleagues say, man, don't, you got to move on. And I'm to the point where sometimes I have a really good lecture and I won't repeat it because I'm like, oh, if there's one or two people that have heard it, I don't want to, you know, I want to bore them, right? And I think there's a fine dance because like knowledge, you have to get some reps at stuff and to embody it both as the giver but also as the receiver, but I just don't want to be stale.
You don't want to have those same stories all the time coming across. I don't think you're gonna be stale. Well, Tim, I know that we're getting close to the end of this the time that we had here, and I just want to thank you very much for spending time with us today to have this conversation. I know that we can probably have a lot of other conversations about a lot of other things that I wanted to today, but my hope is that at least folks can kind of see the importance of not just manual therapy education but just education in general and how that enhances what we can do, and I appreciate your spending time with us today.
Well, it's been a pleasure as always, Derek. It's fun to have these conversations, and I do hope the listeners out there, will have these conversations amongst themselves. And please reach out to me if you want to chat because this areas I'm passionate about.
Awesome, we will do. All right, well, thank you so much, Tim.